record button, and I'll share my screen and we can make a start. Oops, let me just see if I can do that. Okay. All right. We'll start, and as I say, more people will come in as we go. But we go on. But welcome everyone, and I hope you've had a safe week. It's been difficult in many places in the world this week, I think, and so hope you're all well and safe. Today I wanted to discuss the last 2 weeks we've talked about congenital heart disease, and 2 weeks ago we talked about congenital acyanotic heart disease, that is children who aren't cyanosed but present in heart failure. And we talked a bit about the varied causes of heart failure, if you remember, and we tried to cover an easy way to remember all the different causes of heart failure. And then we talked about congenital heart disease as a cause of heart failure, and mostly we talked about left to right shunts, so ventricular septal defects and atrial septal defects and PDAs and AVSDs, atrioventricular septal defects, all those causes of left to right shunts, and they cause heart failure as a form of congenital heart disease. And we also talked about obstruction to the left ventricular outflow tract, so conditions like a coarctation of the aorta or aortic stenosis, they also can cause heart failure, and they can cause heart failure not because of a left to right shunt, but because of obstruction of the outflow of the left ventricle. So today we're going to talk about something a bit different. It's still on congenital heart disease, but the last 2 weeks we've talked about congenital acyanotic heart disease, so children who aren't cyanosed but they present in heart failure. Whereas today we're going to be talking about mostly about children who are cyanosed, and so we'll go through it like that. So as I say, last week we talked about the 75% of children with congenital heart disease who have acyanotic heart disease, and this week we're going to be talking about cyanotic heart disease. And the two major causes of cyanotic heart disease are obstructions to the right ventricular outflow tract. So last week we talked about obstructions to the left ventricular outflow tract, so aortic stenosis, coarctation, that anything that obstructs the outflow tract of the left ventricle, so the aortic valve or the aorta. And this week we're going to be talking about conditions that obstruct the right ventricular outflow tract, so the pulmonary valve or the infundibulum or the ventricle itself particularly. And the other cause of cyanotic heart disease, it can be either obstruction to the right ventricle, or there can be mixing lesions, and I'll explain what that means. And the third cause of cyanotic heart disease or cyanotic cardiac failure is pulmonary hypertension. So if you think about it in that way, with that framework, then you can understand, I think, what's acyanotic heart disease and what's cyanotic heart disease. If it's not completely clear now, I hope it will be as we go through. So we're going to be talking the clinical presentations of cyanotic heart disease, like babies and children that present with cyanosis, and it's because of heart disease. The infant or the child presents with cyanotic episodes, so spells of cyanosis, or the newborn baby who's cyanosed at the time of or very soon after birth. And of course, that baby might have a number of different things. A baby who's cyanosed at birth, often we think that baby must have birth asphyxia, but sometimes that is caused by cyanotic heart disease. And I'll explain the types of cyanotic heart disease that cause that presentation, a newborn baby who's cyanosed at the time of birth. The causes are a bit different to the infant, like an older infant or a child who presents with cyanotic spells or cyanotic episodes. So they're the two common presentations of children with cyanotic heart disease. So let's go through a case first. I mean, this is a typical case, a 4-month-old boy who presents with seizures and collapse, and that occurs when he's upset or crying. Otherwise, he's a normal-looking baby. He's a relatively well-grown boy. His pulses are all normal, But when you look at him, he looks like he's got a big barrel chest. He's got chest hyperinflation. But when you listen to his chest, he doesn't have wheeze or he doesn't have crackles, and there's no hepatomegaly. And his saturations are 88%. What could be causing that? What do you think? Do you have any ideas about what might cause that? I'll just show you his X-ray, I think. Oh, actually, before that. Any thoughts about what might cause that? A 4-month-old boy who presents with seizures and collapse every time he's upset or crying.
TET spells?
Yes, he could be having TET spells. That's right. They could be. He could have Tetralogy of Fallot, and they could be having TET spells. That's the most likely cause, isn't it, in a 4-month-old child with that type of clinical problem. Of course, it could be some other things, and I want you to be whenever you think of cyanotic heart disease, you've also got to think broadly and think of what else could it be. So it could be a respiratory problem. It could be like he's having breath holding spells, and some babies at the age of 4 months will have breath holding, or it could be that he's aspirating. He's got reflux and aspirating, or it could be that he's having seizures. Like primary seizures, such as infantile spasms or epilepsy or something like that. Or it could be, as you said, that he's got Tetralogy of Fallot and he's having TET spells. Or it could be these episodes of cyanosis and collapse and seizures might be related to an arrhythmia. And so what I want you to be able to do is to be able to think broadly about these common clinical presentations and not just focus on the one condition, but think, well, what else could it be? And if it was something else, what clinical information would I have to gather to try to rule in or rule out one of these alternative diagnoses? This is his chest X-ray, and I'm not sure whether you can see it. I'll put the... What do you think about his chest X-ray? Can anyone suggest anything that you see on his chest X-ray?
It's a boot sign.
That's right. He's got what's called a boot-shaped heart, hasn't he? And his heart looks like a boot. And that, what do you see that in, Glanson? When do you see a boot-shaped heart like that?
So tough.
Yeah, typically a Tetralogy of Fallot, isn't it? Typically a Tetralogy of Fallot. And just on the abbreviation, don't use the word TOF. Don't use the abbreviation TOF. And the reason for that is because it could be a tracheoesophageal fistula. All right. And so it's important that when we use abbreviations, they are very clear to people. So anyway, you're right in what you say. A boot-shaped heart is seen in a Tetralogy of Fallot. And yes. What are the other, usually the X-ray features of Tetralogy of Fallot? What are the other X-ray features? There's something else you usually see, and it's not so evident on this chest X-ray, but what I want you to be able to look at is so you've seen the abnormal boot-shaped heart, and then have a look at the lung fields. And typically in Tetralogy of Fallot, the lung fields are very black. They're very black because, why is that?
Because of the decreased pulmonary blood flow through the stenosed valve, pulmonary stenosis.
Yes, that's right. Usually because the obstruction to the right ventricular outflow tract, instead of having plethoric lung fields like you get with a large left to right shunt, because there's a right to left shunt, there's more blood that it can't get out of the stenosed outflow tract. So it goes back through the ventricular septum and then out through the systemic circulation. And so there's a right to left shunt. And what that does is steal blood away from the lungs, and the lungs therefore don't look like they've got normal vascular markings, right? The vascular markings of the lung are because of pulmonary blood flow, and that's a normal phenomenon. And if you've got what we call oligemic lung fields, then the lungs will be very black and translucent. Now, sometimes in Tetralogy of Fallot, you won't get oligemic lung fields, and that's where you've still got enough flow through the pulmonary valve. And there are some children that have what's called an acyanotic tetralogy of Fallot. And that means they've still got the anatomy of a tetralogy of Fallot, but enough blood is getting through into their lungs because the stenosis is not so severe at this point in time. It probably will get severe. So as the child grows, usually they become cyanotic. They go from being an acyanotic tetralogy of Fallot to being a cyanotic tetralogy of Fallot. And that's just because the stenosis gets more severe over time. But when you're looking at a chest x-ray, look for the shape of the heart and also look to see whether the lung fields are plethoric or normal in vascular markings or oligemic. This one looks pretty normal to me. It doesn't look oligemic. So I just wanted to go through what a tetralogy of Fallot is. I think most of you know this, but it's where there's, this is a diagram of a tetralogy of Fallot. There's a ventricular septal defect, often quite a large one, and there's obstruction to the right ventricular outflow tract, right, at the level of the pulmonary artery, and also in the subvalvular level. And that's because of hypertrophy of the muscle, the cardiac muscle. And so there's two reasons why there's obstruction to the right ventricular outflow tract, partly a narrowing at the pulmonary artery and partly hypertrophy of what we call the interventricular septum, or the infundibulum of the heart, right? And so that's why blood can't flow out the pulmonary artery, but instead it flows back into the left ventricle through the ventricular septum and then out through the aorta. And what that means is that blue blood is going out into the ventricle and through the aorta, and normally only red blood or oxygenated blood does that. And so that's the problem. Yeah. Okay. So the tetralogy of Fallot consists of four things: pulmonary stenosis, right ventricular infundibular hypertrophy, this hypertrophy of the muscle there, and a ventricular septal defect, and what's called an overriding aorta, which just simply means that the aorta is very close to the ventricular septal defect. So as soon as the blood goes out into the left ventricle, it preferentially goes up the aorta, and that means blue blood, deoxygenated blood, is all the time circulating through the body, through the systemic circulation. Most babies with tetralogy of Fallot are not cyanosed at birth. And if you see a baby who's cyanosed at birth, then they probably don't have a tetralogy of Fallot, but they become cyanosed in the first, often in the first 6 weeks to 8 weeks of life, and sometimes even later. I'll just admit a few people now. Often these babies don't become cyanosed until about 2 to 3 months of life. And so there is a difference between if you see a baby with cyanosis at the time of birth or in the first day, compared with if you see a baby, an infant with cyanosis at 2 or 3 months of life. The baby with cyanosis at 2 or 3 months of life is much more likely to have tetralogy of Fallot, and the baby who's got cyanosis at the time of birth has something else, and I'll explain what they are. With the tetralogy of Fallot, there's usually an ejection systolic murmur. So we talked last week about different murmurs, and the ejection systolic murmur is typically at the upper left sternal edge, so up here in the pulmonary area, and it radiates typically to the back. So other murmurs give you a murmur an ejection systolic murmur in the upper left sternal edge as well, and I'll explain later on how to distinguish these, but it typically radiates to the back. What you're hearing is the murmur of the blood going through the pulmonary valve when there's a jet of blood going through the stenosed pulmonary valve, a jet of blood going through here. It's useful to know how to treat cyanotic spells, and you can almost always treat them well if you know that it requires several different forms of therapy. The first one is to calm the child if distressed. So I always, often these babies are really very, very distressed. They have severe respiratory distress. Often they're deeply cyanosed, they're crying and they're screaming. And the first thing to do is try to calm the child. So if the baby is being breastfed, then I encourage the mother to try to breastfeed the baby and calm the child down. Sometimes they need some intramuscular morphine or some other analgesic to calm them down. Always give them oxygen, even though the oxygen to start with doesn't always work so well to begin with. And it's only by calming the child that the cyanotic spell resolves. But once the baby's a bit calm, then the oxygen has a chance to work. Sometimes they need an intravenous fluid bolus, so you need to put a drip in and give them a fluid bolus. But often you can get babies over their cyanotic spells by just calming them, by giving them a little bit of morphine or something to calm them, by giving them oxygen. And older children who have cyanotic spells will go into this squatting position where they'll squat down on the floor. And what that does, it increases the venous return to the heart and encourages blood to flow through the heart and into the lungs. And so that's the squatting position. You can do the same in a small baby by squeezing their legs up, like I've shown here, just squeezing the legs up in a flexed position. That does the same thing. So I try to calm them with some, give them oxygen, calm them with breastfeeding if they're not too distressed, and the mother can do that. Give them some IM morphine, intramuscular morphine, a fluid bolus if needed, but usually over a period of a few minutes you can calm them down fairly well. To prevent cyanotic spells, you can give propranolol. So almost all babies with Tetralogy of Fallot should be on propranolol. And what that does, it relaxes. Propranolol is a beta blocker, as you know, and it relaxes the infundibular septum, relaxes this area of muscular hypertrophy here. So instead of that going into spasm when the child gets upset, it tends to relax. And so all these children should be on some propranolol, which can reduce the spells. And so that's really how you manage spells. You just need to know that, because we see a lot of babies who have Tetralogy of Fallot, and sometimes their spells make them very, very upset. An ECG of a child who's got Tetralogy of Fallot, what do you think it would show? We talked about ECGs last week. I want you to just think about what an ECG might show in a child with Tetralogy of Fallot. If you've got obstruction of any chamber, like a chamber in the heart, like the right ventricle, then if there's outflow tract obstruction, what do you expect there to be? What do you expect the muscle to be like?
Hypertrophied.
Good.
Hypertrophied.
That's right. It'll be hypertrophic. So therefore, you're likely to have right ventricular hypertrophy in a child who's got Tetralogy of Fallot. So this is the ECG of a child with Tetralogy of Fallot. And I remember we talked last week about the way you look at an ECG. You first of all look at the heart rate. So 300 divided by the number of large squares. So I've done this for you. It's 1.8 large squares. So 300 divided by 1.8 is 166. We talked then about looking for whether or not there's sinus rhythm. So is there an upright P wave in lead 1 and in AVF? And you can see the P wave is upright, and there's a P wave before every QRS complex. So this child is in sinus rhythm. And we talked about the P wave morphology. And remember that the P wave morphology should be 2 by 2, isn't it? It's 2 small squares up and 2 small squares wide. And here you can see that there's probably there's a bit more than 2 small squares up. There's probably 2.5 or 3 small squares up. And so this suggests that there's right atrial hypertrophy there. right? Which, if you've got obstruction to the right ventricular outflow tract, you'll have both right ventricular hypertrophy and also right atrial hypertrophy. If you've got a tetralogy of Fallot, you might imagine that there would be a right axis deviation, because the right ventricle will be more dominant. It'll be more hypertrophied. And so when we're looking at the axis, remember we said you look at the net deflection in lead 1 and the net deflection in lead AVF. And in lead 1, there's a large negative net deflection, isn't there? So 5, 10, 15, 20 minus 5 or 6. So 20 minus 6 equals 14. The net deflection is minus 14 in lead 1. And the net deflection in lead AVF is positive. It's about 8 up, isn't it? 5, 6, 7, 8, 11 up, and maybe 3 down. So that means it's 8 positive. And so when you draw the vector, if you think about the vector, I'm not sure that I've drawn that. Let me just see. Yeah, if you draw the vector that we talked about last week, then the net deflection in lead 1 is a large negative net deflection of 14, minus 14, and the net deflection in lead AVF is plus 8. And so the vector, the QRS vector, or the QRS axis, is about 160. So it's more than, it's not in this quadrant, and it's beyond halfway in this quadrant to be about 160 degrees. So that's quite a large right axis deviation, depending on the age of the child. Remember I said last week that you can have a right axis deviation in infants up to 2 years of age, but over 160 would be a large right axis deviation. So this child's got peaked P waves, he's got a right axis deviation, and has he got right ventricular hypertrophy? Remember we said the criteria for right ventricular hypertrophy are looking at RV2 plus SV5. So we should look at the R wave in V2. So it's about 12 up, and the S wave, I'll just admit some more people, and the S wave in V5, can you see that? It's about 5, 6, 7. So it's 19. So there's not really any evidence of right ventricular hypertrophy in this case of Tetralogy of Fallot. So the point is, you won't always see all the changes early on in Tetralogy of Fallot. It takes some time for there to be significant right ventricular hypertrophy. But this child's got a right axis deviation, and he's got peaked P waves of right atrial hypertrophy. So when you're looking at the ECG of a child, think, well, if the child's got those features, what could it be? And there's not too many other things that would give you those changes. Remember I said last week that the QRS axis changes with age. I won't go through this again. I sent this around last week, but if you're an adult, then the QRS is always between 0 and 90, but sometimes in children, especially infants, it can be beyond 90 degrees. So it can be in that second axis in this quadrant here. That can still be normal, but this boy's got a very large right axis deviation, so probably that's abnormal. Okay, now we see a number of children who've got Tetralogy of Fallot, like the child I just presented, and sometimes we see them as they get older, and sadly, if they're not repaired, if they don't have surgery, then there's a number of complications that they can present with. And one is, it's not uncommon for them to have strokes. And the reason they have strokes typically is that they have a right to left shunt. And so normally we have small microthrombi that are always that are relatively frequently getting into our bloodstream, and then they go through the lungs and they get largely filtered out by the lungs. But if the microthrombi, which might come from, for example, the lower limbs or the blood vessels somewhere, if the microthrombi get into the right ventricle and then they go straight to the left ventricle and then out the aorta, then they can get to the brain. And so it's not uncommon for children with Tetralogy of Fallot to have strokes. and especially if they get a little infected microemboli, like if they're, say, brushing their teeth and they get some bacteremia, then that can lead to, or if they've got a tooth abscess or something like that and that leads to bacteremia, then they can get the bacteria going directly to their brain. And so strokes or cerebral abscesses are relatively common in children with Tetralogy of Fallot who don't get a repair early in life. And part of that is the right to left shunt because their lungs don't filter out the bacterial microemboli that we've got. And part of that is that when these children have severe hypoxia, like they might have saturations that are in the 70s or 80s, then that hypoxia increases the risk of anaerobic bacteria growing, and they can get often their cerebral abscesses are due to multiple different bugs, but particularly anaerobic bacteria. And when, as you know, when children have Tetralogy of Fallot, because of their hypoxia, they produce more red cells, so their hemoglobin might be 18 or 20, and then they get slow blood flow, particularly in the blood vessels in the brain, and that can lead to strokes. So for all of those reasons, children with Tetralogy of Fallot are more prone to strokes if they don't get repaired. If they have a surgical operation and they get repaired, then they're not really prone to strokes. So for children with Tetralogy of Fallot, you should advise patients on the home care of cyanotic spells so that the parents know how to look after these kids if they have a cyanotic spell. They should all be on propranolol. You should make sure their hemoglobin doesn't go too high. And sometimes if you don't do anything, sometimes with children with Tetralogy of Fallot, the hemoglobin will be more than 20 or 22, and that increases their risk of stroke. So, for some of these children, you need to bring them into hospital once a month or every couple of months and venisect them, take some blood off to reduce their hemoglobin just a little bit. So I try to keep their hemoglobin around about 15 to 17, no more, no higher than that, because that will lead to what we call hyperviscosity, or the blood flow through their blood vessels will be slower and therefore make them a bit more prone to strokes. If possible, they should have surgery, and that's why children with Tetralogy of Fallot should be referred to the cardiac team when they come around. The surgery I won't go into today, but they can either have a complete repair, that is the VSD is closed, the right ventricular outflow tract is opened up. They can have a complete repair, or they can have a shunt. And what that means is that they, instead of most of the blood that goes to their lungs coming through their pulmonary artery, they can have a aorta to pulmonary artery shunt. And that means that some of the blood that goes into their lungs comes directly from the aorta. That's what a Blalock-Taussig shunt is. It's usually from the subclavian artery, which comes off the aorta to the pulmonary artery on the same side. And that can either be a prosthetic tube graft or it can be a direct shunt. There are some long-term complications of children who've got Tetralogy of Fallot, and that can be sometimes even after their surgery, they get recurrent right ventricular outflow tract obstruction. They get blockage to their right ventricle. There's a few other complications, particularly arrhythmias. And so even children that have had their Tetralogy of Fallot repaired, as they grow older, we still need to follow them up to see if they're going to have arrhythmias and other things like that. I call this a Blalock-Taussig Thomas shunt, and the reason I call it, you might have heard of it as a BT shunt, but actually the person that did most of the work for this was a person named Vivian Thomas. Some of you might have heard about this, but there's a very good movie called Something the Lord Made, and it's about Vivian Thomas, who was a African-American who was instrumental in making the Blalock-Taussig Thomas shunt, but he was forgotten in the story, and it was really given credit to Alfred Blalock and Helen Taussig, but actually Vivian Thomas was the man who did most of it. Anyway, that's a side story. But kids who have Tetralogy of Fallot, we should follow these children up to see if they've got an arrhythmia or not, and make sure that their exercise tolerance is okay and they're not getting recurrent right ventricular outflow tract obstruction. Okay, so I've talked a lot about Tetralogy of Fallot because it's the most important cyanotic congenital heart disease. I wanted to touch a bit on the baby who's born with cyanosis. Remember I said that the baby is born with, who's cyanosed at the time of birth, probably doesn't have Tetralogy of Fallot. That baby probably has another form of congenital cyanotic heart disease. And I think last week I talked a bit about the baby who's well at birth and then collapses with shock, often with cyanosis, but not always, collapses with shock in the first week of life. So that baby's born well, but then collapses with shock. And those babies typically have what we call duct-dependent lesions. Last week we talked about left ventricular outflow tract obstruction. So often those babies will have left ventricular outflow tract obstruction, coarctation of the aorta, or critical aortic stenosis, or hypoplastic left heart. Sometimes they'll have sepsis. They're well at birth, but they collapse. And we often think about sepsis, but think also about congenital heart disease. But that's a bit different to the neonate who's cyanosed in the first day of life. Now, those babies can have left ventricular outflow tract obstruction, but they may also have a form of cyanotic heart disease. And the typical one that they have is called transposition of the great arteries. So a TGA, transposition of the great arteries. They can also have other things, of course, like birth asphyxia or pneumonia or sepsis, probably more commonly, or some sort of congenital lung or airway problem like diaphragmatic hernia. But if we're talking about congenital heart disease, the baby who's cyanosed in the first day of life, it typically has a transposition of the great arteries. And that's a bit different to a Tetralogy of Fallot. So let's talk about a TGA, because of all the cyanotic heart disease types I want you to know something about, you need to know about Tetralogy of Fallot, and you need to know something about a TGA.
Well, I unplug it.
That's all. And in the key to understanding a TGA is that the great arteries, the aorta and the pulmonary artery, are transposed. So the aorta comes off the right ventricle. So the right ventricle's here, and this is the aorta, but the aorta comes off the right ventricle, and the pulmonary artery comes off the left ventricle. And so blood simply flows from the left ventricle into the pulmonary artery, and then it comes back into through the pulmonary artery, pulmonary veins, and then back through the pulmonary veins into the left atrium, and then goes round again. All right, and so there's this circulation here, but it never goes through the lungs. And on the right side, I should say it never goes through the systemic circulation, it just goes through the lungs, getting oxygen all the time, but never going through the systemic circulation. Whereas the blood that goes through the systemic circulation only goes out the aorta, through the systemic circulation, all the organs of the body, comes back through the IVC and the SVC, and then goes around again. So you've got two circulations working in parallel rather than in series. And the only way a baby like that can survive is if they've got a ventricular septal defect as well. And many of these babies have a large ventricular septal defect. If they've got a ventricular septal defect, then all the blood just mixes in between. And so then you've got some oxygenated blood going to the systemic circulation, and you've got some deoxygenated blood going out to the lungs. All right, and so there's some mixing. But these babies will be deeply cyanosed, and they usually cyanosed from the time they're born or very soon after that. As I say, they need to survive, they need to have a mechanism of mixing of blood between the left and the right side of the circulation, and that is either a large ventricular septal defect, or that if they have a patent ductus arteriosus, that can be a source of mixing, or if they've got a patent foramen ovale just between the atria, they may have a hole as well, like an ASD, but what we call a PFO, or patent foramen ovale. So anyway, any mechanism for having mixing they can survive. If they didn't have any of those things, then they wouldn't survive more than a few minutes of birth. But sometimes their VSD is large and they can survive. As I said, they're cyanosed in the first hour of life, and that progresses over the first few days. They often have a severe metabolic acidosis as well, and they're very blue and tachycardic. They have a right ventricular impulse. So remember that they have a hyperdynamic circulation with a right ventricular impulse. Sometimes you can't hear a murmur in babies with a TGA. But the X-ray looks like this. And does anyone know what this looks like? What do you call this? Sometimes people look at this and say it's a bit of a boot-shaped heart too. I suppose it is a bit, but there's another phrase for it. And I just want you to look at this. What does it look like?
Egg on the side.
Yes, an egg on the side. Yeah, that's right. And so if you look at the heart shape and think to yourself, does it look like an egg on the side? And if you can draw it like an egg within the heart, and it looks like it's on the side, that's what you see with a TGA, an egg on the side, right? And sometimes you'll see plethoric lung fields as well, because there's a lot of blood that's just circulating around the lung fields. I won't go through this too much. There's a couple of other forms of congenital heart disease that give you cyanosis, particularly pulmonary atresia or tricuspid atresia. But remember, these are all causes whereby there's obstruction to the right ventricular outflow tract, either at the pulmonary artery or at the tricuspid valve. It's doing the same thing as what we talked about last week on the left side of the heart, where you've got left ventricular outflow tract obstruction, either at the level of the aortic valve or the left ventricle or the mitral valve or the aorta. Any of those things can lead to obstruction to left ventricular outflow tract, and any obstruction on the right side, be it pulmonary atresia or tricuspid atresia or Tetralogy of Fallot leading to infundibular hypertrophy, that will also lead to obstruction of the right ventricular outflow tract. And then there's another type that's a bit like a TGA, because you have mixing of blood where you've got just a truncus arteriosus, which is, it seems to be relatively common in Papua New Guinea, actually, a truncus arteriosus, where instead of having a pulmonary artery and a aorta, there's one single trunk coming off the ventricles. And in a truncus arteriosus, you have the child's got a large VSD, and they have a single trunk that comes off that goes to both the aorta and the pulmonary arteries. And in that case, you'll get complete mixing of blood within the ventricles, and the baby will typically be quite blue in a truncus arteriosus. I won't go into those things. I want you to understand the concepts of why you get cyanotic heart disease. And typically it's because of either mixing or obstruction to the right ventricular outflow tract. Right. Okay. I wanted to just go through, for the last 2 or 3 weeks, we've been talking a bit about different murmurs and how you diagnose different types of congenital heart disease. I'll send this slide around because I think I've tried to draw where the murmurs typically are that you hear with different types of congenital heart disease. So 2 weeks ago, we talked about ventricular septal defects. Remember, we said that they're pansystolic murmurs best heard at the lower left sternal edge. And so this is the lower left sternal edge, and this is what a pansystolic murmur looks like, right? It's all the way, this is the first heart sound, the second heart sound, and it goes all the way through systole to the second heart sound, right? And it's consistent all the time. Remember, it's labsh, labsh, labsh. And that's different to a ejection systolic murmur that's much more like labsh, psh, 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 psh. It sounds like that. So it's got a up phase and a down phase, whereas a pansystolic murmur goes all the way through systole. That's what a VSD murmur sounds like. If you hear it at the apex, then it's much more likely to be mitral regurgitation, right? Now, at the pulmonary level, in the pulmonary, the upper left sternal edge, then an ejection systolic murmur. We talked last 2 weeks that it could be pulmonary stenosis, or it could be an ASD, an atrial septal defect, or it could be a tetralogy of Fallot. It's hard to make the distinction between the two, but if it was tetralogy of Fallot, then the child would normally be cyanosed, right? Or it could be pulmonary stenosis and the child's cyanosed, same thing. But if it was an ASD, you wouldn't expect that child to be cyanosed. And so if you hear that type of murmur in the upper left sternal edge, then have a listen to the second heart sound and have a listen to see whether the second heart sound is widely split or not. The first time you listen, you won't hear this. But if you keep practicing listening to hearts, then you may be able to detect the difference in splitting of the second heart sound, which after a while you'll be able to do. And so then there's a characteristic pattern. Remember, an ASD usually occurs in an older child. There's an ejection systolic murmur. Usually they're not in severe heart failure. There's an ejection systolic murmur at the upper left sternal edge. You get a wide splitting of the second heart sound. Whereas for pulmonary stenosis or for tetralogy of Fallot, that usually occurs in infants and you see them with cyanotic spells and they have the same murmur, but they don't have fixed splitting of the second heart sound. So there are patterns that over time you can start, I guess, recognizing, and you don't accumulate all of this sort of I guess, skill and, if you like, all at once. You just have to build on, your knowledge about heart murmurs and what they tell you and what X-rays look like and what the ECG would look like in these children. And gradually over time, you'll build up your knowledge. Similarly, we talked about 2 weeks ago and last week, we talked about a PDA. Remember, that's a large left to right shunt. I mean, it doesn't have to be large. It can be small or it can be large, but sometimes there's a large left to right shunt, and they have what's called a holosystolic murmur or a continuous murmur. So it goes through systole into diastole. So it sounds like whoosh, 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 whoosh. You can hear it going all the way through systole like a pansystolic murmur, and then it goes into diastole. And that's best heard also, you typically hear it over the chest, but you can hear it at the upper left sternal edge, but it doesn't sound like a whoosh, 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 whoosh. It's like whoosh, whoosh, whoosh. You can hear it going all the way through systole into diastole. As you get, as I say, just listen to more hearts and you'll hear this stuff. Okay, right. Now, the last thing I wanted to talk about today, we've talked about tetralogy of Fallot and TGAs, transposition of the Great Arteries. The last thing I wanted to talk about today was pulmonary hypertension. And I wanted to talk about pulmonary hypertension because it's in the differential diagnosis of children who have recurrent cyanosis, right? And so it's in the differential diagnosis of children who have, for example, a tetralogy of Fallot. Not that they get pulmonary hypertension, but they present sometimes present in a similar way with recurrent cyanosis. And so, and we see quite a bit of pulmonary hypertension in PNG, particularly in the highlands. And I wanted to go through first of all, the clinical manifestations of pulmonary hypertension, then say something about the causes, and then we'll talk about the management of pulmonary hypertension. So the first thing is, there are many manifestations of pulmonary hypertension, but so you need to know how to recognize it. And these children often present with recurrent or persistent respiratory distress. And so they may present with frequent, we might say, well, recurrent pneumonia or chronic pneumonia. They present usually with recurrent or persistent respiratory distress, and they're usually desaturated. And they often have episodes of severe cyanosis. So you might look at them and say, oh, they're likely to have tetralogy of Fallot, but maybe it's because of pulmonary hypertension. They usually have, remember 2 weeks ago, we talked about the different types of heart failure, and one type being congestive heart failure, and then there's congestive left heart failure and congestive right heart failure. And children who have pulmonary hypertension usually have congestive right heart failure. They'll have, because of their high pulmonary artery pressures, then they'll have right ventricular dilatation, and their right heart will be under stress and failing. All right, the right side of the heart is not used to dealing with high pressures. And so when the right side of the heart has to deal with high pressures, it goes into failure more quickly than the left side of the heart. And so these children often have hepatomegaly because they have a congested right heart. Remember, if you've got right ventricular dilatation and high right ventricular pressures, then your central venous pressure will be high, and that leads to backflow pressure in your superior vena cava, in your IVC, and the veins that drain the liver. And that's why the liver becomes large when you've got congestive right heart failure, from whatever cause, even if it's a rheumatic heart disease causing right heart failure, or tricuspid regurgitation. Anything that leads to right heart failure will lead to congestive hepatomegaly, right? They're usually tachycardic, and sometimes they have a right ventricular heave because their right ventricle is pumping under pressure, all right? And so they'll have a large, often visible or palpable right ventricular impulse, and they may have a loud pulmonary second sound. So they're the clinical features of pulmonary hypertension. Now, most children who have pulmonary hypertension don't have all of them. They may have just some of them. And so you need to be alert to the child with some of these clinical features and think to yourself, well, do they have any other features that might suggest right pulmonary hypertension and right heart failure? And you remember on the ECG, if you've got pulmonary hypertension, then you might also have, say, right ventricular hypertrophy or right atrial hypertrophy. So they might have peak P waves on their ECG, or they might have large R waves in the right ventricular leads, or they might have a right axis deviation. So now you're starting, I hope, to build up a knowledge of the different types of heart failure and what the ECG can tell you, and what chest X-rays and the clinical pattern of these conditions. Let's talk about the causes of pulmonary hypertension, because we usually, I think, default to the idea that pulmonary hypertension is due to pneumonia, and sometimes it is, and sometimes, especially in the highlands, then pulmonary hypertension can be caused by pneumonia and hypoxia, or the altitude that exists in the highlands. But remember, there's other causes too. And I just want you to, if you see a child who's got the clinical features of pulmonary hypertension, you should always ask the question, well, what is the cause of this pulmonary hypertension? Is it just because of pneumonia, or is there something else going on as well? And in your mind, you need to be excluding these things. It looks like a long list, but it's not hard to exclude them based on history and examination. And so I always go through this list in my mind when I see a child who I think has got the clinical features of pulmonary hypertension. Well, firstly, the first thing is, I shouldn't use an abbreviation, but PPHN, persistent pulmonary hypertension of the newborn. We see that quite a lot in newborn babies that have birth asphyxia, isn't it? That's quite different to an older child with pulmonary hypertension. But PPHN is a form of pulmonary hypertension just because the pulmonary vascular resistance hasn't fallen, and you've still got a flow of blood right to left through the PFO or the duct. But if we're talking about older children with recurrent or chronic respiratory distress and episodes of cyanosis, then the first thing you need to think of is, do they have some cause of high pulmonary blood flow, like a large left to right shunt that might be causing pulmonary hypertension because of excessive blood flowing through the lungs? Like if they've got a VSD or an ASD or a PDA, then that can cause pulmonary hypertension. Usually they'll manifest other features like congestive heart failure as well. Could they have some, now this is getting a bit complicated, but could they have what we call pulmonary venous hypertension? And so sometimes pulmonary hypertension is because of high pulmonary artery pressures, and sometimes it's because of pulmonary venous obstruction, right? So if you've got mitral stenosis, then there's a backflow of blood through the pulmonary veins, through the left atria into the pulmonary veins, and then there's a backflow of blood, and that causes there to be high blood pressure in the arteries that are trying to pump blood, the pulmonary arteries that are trying to pump blood through the lungs. And so anything that causes an obstruction to the pulmonary venous drainage through like mitral stenosis or obstructed pulmonary venous drainage, TAPVD, total anomalous pulmonary venous drainage, that can cause pulmonary venous hypertension. They have pulmonary hypertension. It's just the origin of it is from the veins. Then there's the most common cause of pulmonary hypertension, I think, in the highlands, and that's just pneumonia, and that's associated with hypoxic pulmonary vasoconstriction. I won't go through that in more detail, but to know that children with pneumonia can develop pulmonary hypertension, usually acute. It usually gets better when they get their pneumonia treated and they get oxygen. Oxygen is the best treatment for pulmonary hypertension, the best, better than sildenafil or any of those other drugs. Oxygen is the main therapy. Then there's the children that have some form of chronic lung disease, and they can have pulmonary hypertension just like old people who've got chronic lung disease can have cor pulmonale or right heart failure. That's because of pulmonary hypertension. And so babies that are born with chronic lung or develop chronic lung disease in the newborn period, or if they've got fibrotic lung disease, say from TB or HIV, then they can develop pulmonary hypertension. Or if they've got pulmonary hypoplasia, if they're born with lungs that are too small, then they can have chronic lung disease and pulmonary hypertension. And then there's the occasional patient that has pulmonary vascular problems. I've got a child at the moment who's got severe pulmonary emboli, and that caused him to have severe pulmonary hypertension. And then, of course, we know that with COVID-19, not so much seen in children, although it does sometimes occur in children, that can cause pulmonary vascular problems and pulmonary emboli, and that can cause pulmonary hypertension in some children. And then there's a group of conditions I really want you to know about, and that's the other causes of pulmonary hypertension, and they're nutritional. And there are children that have vitamin C deficiency or thiamine deficiency. So if kids have malnutrition, then they can have pulmonary hypertension from scurvy or thiamine deficiency. And I think this might be a feature of pulmonary hypertension in children in Papua New Guinea, particularly in the highlands, where there's the combination of pneumonia, hypoxia, and malnutrition. If you see children that have malnutrition with evidence of pulmonary hypertension, then you should think, well, maybe they've got vitamin C deficiency or thiamine deficiency. I won't say any more about that, but I think it's important for us to consider. And I always treat these children with both thiamine, multivitamins, because that has thiamine in it, and vitamin C, because sometimes that makes them a bit better. It's a good treatment. Oxygen, multivitamins can help their pulmonary hypertension. I won't go through this in too much detail, but you just need to, maybe a couple of things. One is that the normal pulmonary artery pressure is not like the systemic blood pressure. It's much lower normally. And a child with a mean pulmonary artery pressure more than 20 millimeters of mercury, remember our mean blood pressure is 60 or 70, but a patient who's got a mean blood pressure more than 20 millimeters of mercury has a degree of pulmonary hypertension. But children who have severe pulmonary hypertension usually have a pulmonary artery pressure that's more than half their systemic pressure. And sometimes it's equal to their systemic pressure. And that can be very serious if they've got a PA pressure, a pulmonary artery pressure that's equal to their systemic pressure. Usually your pulmonary vascular resistance drops rapidly after birth, and then over the next 6 months drops even slower. So it drops below 20. So normally our mean PA pressure is below 20 by about 6 months of age. But babies that are born, the reason why babies have PPHN, persistent pulmonary hypertension of the newborn, is because even though the PA pressure drops a bit after birth, it remains susceptible. So if these babies, they might deliver, they might have a bit of birth asphyxia, They might, someone might not recognize it and they get transferred out of the labour ward to be in the postnatal ward, and they might have a bit of apnea, or they might be a bit hypoxic, and then because of hypoxia, then their PVR, their pulmonary vascular resistance, suddenly rises, and they get much worse pulmonary hypertension, and then they're shunting blood all from right to left, and they become very cyanosed. That's what PPHN is, and it's this combination of babies that have hypoxia at the time of birth, have some birth asphyxia, and then they're not managed so well in the first day of life, and then they become very unwell, usually in the first 24 hours. Think of pulmonary hypertension as being primary or secondary. That is, some children have primary pulmonary hypertension, that is that we can't find a cause, but often it's secondary to other causes, like I mentioned, either a large left to right shunt, or nutritional deficiencies, or pneumonia, or something like that. Yeah. Try to make a distinction sometimes between pulmonary venous hypertension and pulmonary artery hypertension. This is sometimes difficult, but the causes are different. Remember, pulmonary venous hypertension occurs because of, multiple stenosis, or TAPVD, or anything that causes a blockage of the venous drainage of the lungs. And pulmonary artery hypertension usually occurs because of lung disease, or usually lung disease. And remember that pulmonary hypertension affects the weaker ventricle. It's a weaker pump, and so the right ventricle doesn't have the same, I suppose, strength as the left ventricle, and it can dilate much quicker. All right. And the other important thing, I think, with all of this is that sometimes for children with pulmonary hypertension, you can make them a lot better by just calming them and reducing their agitation, reducing their stress. And so I find children with pulmonary hypertension, they usually get very stressed when you're trying to, if you're taking too many goes at trying to put a drip in, or you're, trying to do things to them that are painful or damaging, or they're just distressed by you, examining them, then they're often, their pulmonary hypertension is worse. So I find you can really usually help calm them, give them oxygen. You can usually make them a lot better. Okay. There are some X-ray changes of pulmonary hypertension, and partly it depends on the type of pulmonary hypertension. And this was a child who had chronic lung disease, who had pulmonary. So this is a typical child, I suppose, who like in PNG we often see with, say, HIV-related chronic lung disease, or TB-related chronic lung disease, who gets pulmonary hypertension. And what I want you to look at is the pulmonary arteries. And normally we don't see the pulmonary arteries being very large, but here, these are the pulmonary arteries. When we look at it, we might say, oh, there's some big lymph nodes or something in the perihilar region. No, these are the pulmonary arteries. So typically with pulmonary hypertension, you'll see large pulmonary arteries. And sometimes, depending on the cause, you'll actually see there's large pulmonary arteries, and then you don't see much in the way of vascular changes. With this child, you can because of the chronic lung disease, but sometimes you see what's called pruning of the pulmonary vascular bed. And that is, you see the blood flowing into the proximal pulmonary arteries, but you don't see it going all the way out to the rest of the lung. That's the radiographic features of pulmonary hypertension, depending on the cause. I'll just show you another child. This is also a child who's got severe chronic lung disease, and she had severe, you can see the pulmonary arteries are very large here. And that's the radiographic manifestation of pulmonary hypertension. Okay, look, I think we might actually stop. Oh no, I'll just show you one more thing, and that is what the echo looks like. And I wanted to, over the coming, throughout the year sometime, I want to go through echocardiography in a bit more detail. I don't want to teach you everything about echocardiography because I don't know everything myself. There's other people who can teach you that, but I just want to explain. It's useful for us to learn a bit about echocardiography, and today I'm going to just tell you about the echocardiographic changes of children who've got pulmonary hypertension. And it's not that hard to sort of to imagine what those echocardiographic changes are. The two images that it's useful to look at for pulmonary hypertension are, first of all, the parasternal short axis view. And what you do is hold the probe in at the upper left sternal edge and orientate the probe in the way that you see this, the left ventricle and the right ventricle. And so you see a cross-sectional view of the left ventricle and the right ventricle. And I'll show you what it looks like for children with pulmonary hypertension. And then the other image that I look for pulmonary hypertension is an apical four-chamber view. So normally we would put the probe at the apex and orientate it so you see the left ventricle, left atrium, right atrium, right ventricle. It looks like an inverted heart, doesn't it? It's an inverted upside down heart, but this is the way the apical four-chamber view looks, the left atrium, right atrium. Sometimes the echo machine will flip it around so it looks in the correct way. That's just the echo machine having the sophistication to flip it around, but sometimes it'll look like this. So they're the two views you should look at for pulmonary hypertension, the parasternal short axis view and the apical four-chamber view. And this is what the parasternal short axis view looks like. So, and this is a child who's got severe pulmonary hypertension. And I want you to look at, normally, so this is the left ventricle, right? And this is the right ventricle. And normally the left ventricle would not look like this. It wouldn't look collapsed like this. It would look larger than the right ventricle. And normally the right ventricle wouldn't look dilated like this. It would look a bit more like this. So left ventricle being large, right ventricle being smaller, and being on the edge rather than being the dominant circle, right? And so here you see there must be a lot of pressure in the right ventricle because it's pushed the interventricular septum across to the left ventricle. And you can tell that's the left ventricle because the left ventricle is all thick-walled, right? It's thick-walled. Here too, the left ventricle is really thick-walled, right? And so this is what it looks like on the parasternal short axis view of a child who's got severe pulmonary hypertension. A very dilated right ventricle. The septum is pushed across to the left ventricle, and the septum is hypertrophied, just a normal left ventricular muscular hypertrophy, but the left ventricle is collapsed. And the reason why these children go into heart failure is because their right ventricle goes into heart failure, and then the septum pushes across to the left ventricle, and it doesn't allow the left ventricle to fill with blood during diastole because the right ventricle is all dilated and pushed the septum across. That's what it looks like. And then the second view on the echo is, remember I talked about the apical four-chamber view, and sometimes, as I said, your echo machine will flip it around. In this case, it has flipped it around. The right atrium's here, the left atrium's, oh, excuse me. Hello, it's Trevor Duke speaking. Hello. Oh. Okay, sorry about that. So here the right atrium is here, the left atrium is here, the left ventricle and the right ventricle. And what you can see just is that there's a marked dilatation of the right atrium and the right ventricle. It normally doesn't look like this. It normally looks much smaller than the left ventricle and the left atrium. But in this case, it's the opposite. The right atrium is large, the left atrium is large. And this is, again, another child who's got severe pulmonary hypertension where you've got right ventricle and right atrial dilatation. And if there's marked right ventricular dilatation from pulmonary hypertension, often you get what's called tricuspid regurgitation. There's blood flows through the ventricle into the atrium. I won't go into that in detail, but over time, again, I think you'll get used to looking at echoes, and you need to match that with the clinical pattern of the disease, the ECG findings, the chest X-ray findings. And so I think you'll learn that we can make these diagnoses based on the history and the examination and a detailed differential diagnosis and simple things like an ECG and a chest X-ray, and you'll get used to looking at echoes. So that's really all I had to say. I'll just show, well, I'll show you one more thing, and this is for your information. It's just a CT scan of a child who's got severe pulmonary hypertension from chronic lung disease. And I just want you to look at this. This is the pulmonary artery, and you can see how dilated it is. This is the aorta, the left ventricle, the aorta. This is a contrast enhanced CT scan, and you can see how dilated the pulmonary artery is. And these are the, remember I said you on the chest x-ray, you can see big pulmonary arteries in the left and right, and you can see the pulmonary artery here and the pulmonary arteries going down here. And so you won't see too many CT scans looking like this, but it's the understanding that you can have that usually with children with severe pulmonary hypertension from chronic lung disease, you get large pulmonary arteries. I won't go into that too much, but I'm going to stop there and see if anyone's got any questions. But I hope that was useful. We talked about really cyanotic heart disease today, and we've talked about Tetralogy of Fallot. We've talked about transposition of the Great Arteries. We've talked about the child who has cyanotic episodes, and we've talked about the newborn baby who is cyanosed in the first hour or day of life. And we've talked about pulmonary hypertension and how to recognize it. So that's all I wanted to discuss today. I just want to, as we go through these things, I want to build up your knowledge about pediatric cardiology, and you can't learn it all in 1 year or even a few lectures or even a year. It just takes time, and the more we see children and the more we examine them, the more we'll learn. So I'm going to stop recording now, actually.